So I've been called to a 70-year-old male with a chief complaint of chest pain who has collapsed. So he presented as being pale and clammy. His eyes were open to voice, but he was unable to obey any commands. His wife said that he was feeling, he had an acute onset of chest pain and couldn't stand due to syncope and dizziness. He's got a past medical history of a myocardial infarction 5 years ago, and he said that the chest pain he's feeling today is different. He is on Cilazapril and aspirin. His heart rate was 170, his blood pressure is 70/40, his respiration rate was 18, VGL 7.6, and temperature is 37. And the 12-lead ECG showed that he was in ventricular tachycardia. So, correlating what he's presented with, he's severely compromised, he is hypotensive, and he has ventricular tachycardia. So this patient is status 1, and I'll be calling backup. So AUT 1 to comms.
Comms, AUT 1, go ahead.
We've got a status 1 patient requesting R50.
Copy that.
Okay. So because of his level, so ventricular tachycardia, it's basically a broad complex tachycardia originating from the ventricles. I'm just going to be ruling out other differentials before performing any intervention. So this is not SVT with aberrancy because he doesn't. There is precordial concordance. The QRS is longer, and there's right axis deviation, and he is also older and more severely compromised, so this is more likely to be VT than SVT. This is not septic shock because he's been seen to be well. We couldn't find any signs of infection, and he had a temperature of 37, which is all right. Look, this is not not due to electrolyte abnormality because he's got no history of such, and he's got no history of dialysis as well. It's not anaphylactic shock because he's got no other systemic signs of anaphylaxis apart from hypotension. Not hypovolemic or hypovolemia or hypovolemic shock because he's got he hasn't lost any blood recently, and no history of trauma, recent history of trauma, and no signs of dehydration. So because the patient's in cardiogenic shock due to his ventricular tachycardia, we'll be performing cardioversion. So first, we'll have to lie the patient supine as he is. Next, I'll be gaining IV access using a large bore cannula. Because the patient's unable to obey commands, I won't be giving him any pain relief. But if pain relief was required, I'll be calling clinical to administer ketamine. So next, I'm going to be syncing the. So we've got him we've got a defibs on him. The defib is in manual mode, and we've chosen lead 2 to show the highest, the tallest R wave, and we are going to be syncing, ensuring that there are pacing spikes on each R wave. Okay. Next, I'm going to be printing it out. Okay, so I'm printing out just to double check that there is a pacing spike on top of each R wave. Okay, so now that that's confirmed, been confirmed, I'm going to be using my checklist to ensure that I've covered every steps before cardioverting the patient. Okay, so first, place the pads on the apex sternum, which is done here, and ensure that the defib is in manual mode, which it is. Select an R wave, the tallest R wave, which it is. Okay, and select synchronized mode, so that's good. Confirm there's a detection symbol above every QRS complex. Yep. And ensure the patient has received adequate sedation. As mentioned before, sedation isn't required in this circumstance. Select the joules, so it's going to be at max joules at 360, and I'll be charging the defibrillator. Okay. So at this stage, I'm going to make sure that everyone is clear, no one's touching the patient. Okay. and ensure that it's still in VT. And when I'm shocking, I'm holding it and looking at the patient, making sure no one's touching the patient. Okay. Okay. So now I'm going to determine the level of cardiovascular compromise that the patient is in now. Administering a second cardioversion. So this would be when the patient's still in ventricular tachycardia. You would have to ensure that the monitor is still in synchronized mode.